If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. Today, we're going to do an up-to-date review of the diagnosis and initial assessment of COPD in adults according to the NICE guideline NG115, always focusing on what is relevant in primary care only. I will be creating further episodes on the management of stable COPD and COPD exacerbations, so stay tuned. Right, so let's jump into it. The diagnosis of COPD is suspected on the basis of symptoms and signs and is confirmed by spirometry. So, we should suspect COPD in people who are 35, who have a risk factor, generally smoking or history of smoking, and who present with one or more of the following symptoms: exertional shortness of breath, chronic cough, regular sputum, wheezing, and frequent so-called winter bronchitis. As part of our assessment, we will also check for signs such as weight loss, reduced exercise tolerance and fatigue, waking at night with breathlessness, and ankle swelling. Chest pain and hemoptysis are uncommon symptoms in COPD, and they should raise the possibility of alternative diagnoses. The Medical Research Council, or MRC, dyspnea scale should be used to grade the breathlessness. So let's have a look at it. Grade 1 is when the patient is not troubled by breathlessness except on strenuous exercise. Grade 2 is when the patient develops shortness of breath when hurrying or walking up a slight hill. Grade 3 is when the patient walks slower than contemporaries on level ground because of breathlessness, or has to stop for breath when walking at own pace. Grade 4 is when the patient stops for breath after walking about 100 meters or after a few minutes on level ground. And Grade 5 is when the patient is too breathless to leave the house or breathless when dressing or undressing. Once we have suspected COPD, we should confirm it with spirometry. So spirometry should definitely be done at diagnosis, but it can also be performed to reconsider the diagnosis for those who show an exceptionally good response to treatment and to monitor disease progression. Let's take a moment here to learn about spirometry interpretation. The key measurements are forced expiratory volume in 1 second, or FEV1, which is the volume exhaled in the first second after deep inspiration and forced expiration, and it would be similar to the peak flow rate. Forced vital capacity, or FVC, which is the total volume of air forcibly exhaled in one breath, and the FEV1-FVC ratio, which can be expressed as a figure or as a percentage. Both FEV1 and FVC values are compared to predicted values based on sex, age, and height. So taking this into account, the normal reference ranges are FEV1 is greater than 80% of predicted, FVC more than 80% of predictive, and FEV1-FVC ratio greater than 0.7 or 70%. A typical restricted spirometry pattern would be a reduced FEV1 of less than 80% of the predicted value, a reduced FVC, also less than 80% of the predicted value, and a normal FEV1-FVC ratio, that is, a ratio greater than 0.7. This is because although both FEV1 and FVC are reduced, the FVC value is reduced to a greater extent than the FEV1. On the other hand, a typical obstructive spirometry pattern would be a reduced FEV1 of less than 80% of the predicted value, a reduced FVC compared to the predicted value, although there are occasions when the FVC can be normal. However, because FEV1 is reduced to a greater extent than FVC, this means that the FEV1-FVC ratio will be reduced below 0.7. So in principle, could we diagnose COPD just with typical symptoms and a typical obstructive pattern on spirometry? What about doing reversibility testing? And this is where NICE gives slightly ambiguous advice. On one hand, first it says that we must measure post-bronchodilator spirometry to confirm COPD, but later it says for most people, routine reversibility testing is not necessary because it may be unhelpful or misleading. But before we try to clarify this further, let's look into reversibility testing itself a bit more. If we're doing reversibility testing because of wanting to rule out or confirm asthma, we should stop any inhaled short-acting beta-2 agonists or anticholinergics like ipratropium at least 6 hours before testing. LABAs should be stopped at least 12 hours before testing and LAMAs at least 24 hours before. Reversibility is considered positive if the FEV1 increases by at least 12% and at least 200 milliliters compared to the pre-bronchodilator test. However, some argue for an increase of at least 15% instead of 12%. So why does NICE say that reversibility testing may be unhelpful or misleading? This is because repeated FEV1 measurements can show small spontaneous fluctuations. The results of a reversibility test performed on different occasions can be inconsistent and not reproducible. Over-reliance on a single reversibility test may be misleading unless the change in the FEV1 is greater than 400 milliliters. The definition of a significant change is purely arbitrary, and response to long-term therapy is not predicted by acute reversibility testing. Consequently, if we want to differentiate between COPD and asthma, we can frequently do so on the basis of history and examination rather than reversibility testing. And whenever possible, we will use clinical features to differentiate between them. Let's have a look at these clinical features. A positive smoking history is almost always present in COPD, whereas it is only possible in asthma. Symptoms before the age of 35 is very rare in COPD, whereas it is common in asthma. A chronic productive cough is common in COPD, but uncommon in asthma. Breathlessness is persistent and progressive in COPD, whereas it is variable in asthma. Nighttime waking due to breathlessness or wheeze is uncommon in COPD and common in asthma. And finally, significant diurnal or day-to-day variability of symptoms is uncommon in COPD, but common in asthma. When diagnostic uncertainty remains, or both COPD and asthma are present, we will use the following findings to help identify asthma. A large response that is over 400 mL to bronchodilators, a large response that is over 400 mL to 30 mg oral prednisolone daily for 2 weeks, or serial peak flow measurements showing 20% or greater diurnal or day-to-day variability. Also, we can talk about clinically significant COPD if the FEV1 and FEV1-FVC ratio return to normal with treatment, and we should reconsider the diagnosis of COPD if there is a marked improvement with inhaled therapy. So, in summary, according to NICE, although we should do reversibility testing to confirm the diagnosis of COPD, asthma and COPD can usually be distinguished on the basis of history and examination. If diagnostic doubt remains, or where the patient is thought to have both COPD and asthma, reversibility testing or serial peak flow rate measurements can assist in the diagnosis. So we have now made a diagnosis of COPD based on the clinical presentation and spirometry. Are there any other investigations that we should organize? Well, at the time of diagnosis, in addition to spirometry, all patients should have the following: a chest X-ray to exclude other pathologies, a full blood count to identify anemia or polycythemia, and we should also calculate the BMI. Additionally, we will perform further investigations depending on the circumstances. For example, sputum culture if sputum is persistently present and purulent, serial home peak flow measurements to exclude asthma if diagnostic doubt remains, ECG, serum natriuretic peptides, and an echocardiogram if cardiac disease or pulmonary hypertension are suspected because of a history of cardiovascular disease, hypertension or hypoxia, or clinical signs such as tachycardia, edema, cyanosis, or features of cor pulmonale. CT scan of the thorax to investigate symptoms that seem disproportionate to the spirometric abnormality. Exclude other lung diagnoses such as fibrosis or bronchiectasis, and investigate abnormalities in on-chest X-ray. Serum alpha-1 antitrypsin to assess for deficiency if early onset, minimal smoking history or family history, and transfer factor for carbon monoxide or TLCO to investigate symptoms that seem disproportionate to the spirometric impairment. When discussing prognosis and treatment, we will look at investigations, smoking status, frailty and multimorbidity, symptoms such as breathlessness using the MRC scale, symptom burden using assessment tests like the COPD Assessment Test Score or CAT score, and exercise capacity using the 6-minute walk test. Links to these tests can be found in the episode description. Chronic hypoxia, cor pulmonale, and whether the person meets the criteria for long-term oxygen therapy and or home non-invasive ventilation. Low BMI and the severity and frequency of exacerbations and hospital admissions. We will assess the severity of airflow obstruction according to the reduction in FEV1 post-bronchodilator. There are 4 stages according to NICE. Stage 1, or mild obstruction, is when the FEV1 is greater than 80% of predicted. However, we can only make a diagnosis here if they have COPD symptoms. Stage 2, or moderate obstruction, is when FEV1 is between 50 and 79%. Stage 3, or severe obstruction, is when FEV1 is between 30 and 49%. And stage 4, or very severe obstruction, is when FEV1 is below 30% or below 50% with respiratory failure. We will refer people for specialist advice if they have severe disease or confounding factors such as cor pulmonale, need for long-term oxygen, steroids or nebulizer therapy, dysfunctional breathing, and for the assessment of pulmonary rehabilitation. In addition, we may also refer at an early stage, for example, if there is diagnostic uncertainty, if the patient requests a second opinion, if there is a rapid decline in the FEV1, if they are under 40 years of age or they have a family history of alpha-1 antitrypsin deficiency, if the symptoms are disproportionate to lung function deficit, if they have frequent infections in order to exclude bronchiectasis, and if they have hemoptysis to exclude cancer. We have come to the end of this episode. Remember that this is not medical advice and it is only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.